We will just start. In last 2 days, day before yesterday, we started having some discussions about how to approach a patient and how to do evaluate a patient when you are being called to evaluate the patient and proceed for any surgery. Okay, so that was the first session, was about some words about how to evaluate a patient on the basis of history, examination, and investigations. And yesterday I just discussed some points related to some of the major investigations we did discuss about some CBC, how to evaluate some electrolytes. And today we will just continue from where we were yesterday. So, just a second, please. So, actually, if I just in which you will see a number of people doing INR or PT, APTT. Okay. So specifically, in which conditions you actually need PTINR? Do you need it for all surgeries? The answer is no. Okay. Especially if, for example, you have any problem with the liver, any problem with the kidneys. Okay. Then some patients on anticoagulant. Okay. And now I will just tell you, I will just increase this domain to few more tests, like which we do intraoperatively, as I mentioned yesterday about point of care testing. So ACT is activated clotting time, is a point of care testing, which is you can say a little bit replacing APTT. Okay. This is one thing. And actually, in addition to being done in the lab, INR is also being done as a point of care testing. There is a machine in which you can just put the blood and you will get the report of INR. And in the same list, I will add the thromboelastic evaluation in the form of either ROTAM or TEG. This is also because there are two things. One is coagulation, and other thing is with relation to platelet function. Actually, a number of people confuse these two things. There are some things which are affecting purely coagulation, and there are some things which are affecting platelet function. Number again, there is one number and then function. Like I give you an example, in renal failure, you will have maybe good numbers of platelet, but they are not functioning because they have become impotent, because they need something which is called as factor 8, and they need something which is called as von Willebrand factor. So there they are angry with each other. Okay, so what happens, that there is not good communication between these platelet, this factor 8, and WBF. So they are angry, they are not happy. So their so maybe the platelet count is good, but platelet function is not good. Okay, so for that, actually you can do either CTBT, clotting time, bleeding time, or there is a test which is called as platelet function assay. It is not available everywhere, and maybe it's, but theoretically at least you should be knowing that number of times platelet count is normal, but platelet function is not good. Okay, so even if you even and another thing, even if you, for example, you will see people listening, INR is good and platelet number is good, but I will say that always consider, in CRF patient, a number of people give spinal, but believe me, it's always a controversial thing. Okay, you should be thinking risk versus benefit. If there are more benefits, only then you should do it. Otherwise, it's not advisable, at least epidural, because epidural will not be a good choice if you have any doubt, because these patients usually have platelet dysfunction, which is functional problem, not the number. And INR may be normal. INR will be normal, but platelet function, because the platelet maybe are on the background, but the final step in the hemostasis is platelet. Without platelet, because all other coagulation factor will cause fibrin, this, but the stamp will be done by platelets. So if platelets are not functioning nicely, maybe the clot strength will not be good. Okay. So platelets are the boss, you can say mudir. So if they are not working nicely, maybe everything is normal, but you can have problem. Okay. So always epidurals, you should, I'm not saying that it's contraindicated, everyone is doing it, but you should be very careful about doing epidurals if you have a patient with CRF. So try to find a compelling indication to perform epidural. Otherwise, I think it is better not to do it. You can follow your guidelines, hospital guidelines, or your personal choice, or even personal experience is a big thing. But in my opinion, this is the thing which you should be considering. Yes, spinal, single shot spinal with a, for example, 27 gauge pencil point needle, okay, is maybe acceptable. But epidural with 16 or 18 gauge needle, it's something you should be uh, thinking before finalizing the decision. Okay. So again, I repeat, INR, PT have, if you want to see what will you do, it will be for vitamin K dependent factors 2, 7, 9, and 10. Okay. So PT is showing the intrinsic, sorry, extrinsic pathway. Okay. And APTT, or intraoperatively, we are doing ACT, which is also being done in cardiac surgery. Okay. And usually they are doing it as a point of care testing. And they take it, for example, normally it will be around 100. So they, after giving heparin, they want to move it around 400. Okay. And another point of interest in the same discussion, because heparin acts on antithrombin 3. So there are some people, I'm sorry, pardon me for my handwriting, because I'm using the stylus and I'm not very expert in doing it. So unfortunately, it's not giving a very good result. Anyways, antithrombin 3, and in some patients, antithrombin 3 is deficient. So in that case, you have given heparin, but ACT will not be rising. Okay. Okay. So in that scenario, what you need to do give is you have to give FFPs. You will be surprised. Maybe some people who are doing cardiac anesthesia maybe know about it, but some people who don't do cardiac anesthesia maybe are unaware of it, because in some conditions FFPs, you need to give FFPs before giving heparin, because everything will be normal, everything's apparently normal, so you will give FFPs and it will have antithrombin 3 as well. Then you will give heparin and heparin effect will come. Okay. So this is some additional point. This is not related clearly to our discussion, but when we are discussing some points, some practical points about coagulation, I found it appropriate to just recall this point as well. So INR, platelet count, platelet function, ACT, APTT, and this ROTAM and thromboelastography. Actually, both of them are alike. These are two different companies which are doing it. Okay. The only difference is that in one, just a second, let me see some messages. What about repeating heparin? Heparin, even if you will repeat Zenab, the effect will not come. Okay. Because heparin needs antithrombin 3. So if antithrombin 3 is deficient in some patient, heparin effect will not come. Okay. I hope you receive, like, you got the answer. So ROTAM and thromboelastography are actually the same. They are, you can say that they are point of care viscoelastic assessment of the, like, coagulation function. Okay. And you can say that you will find the result, whatever result will be, you will decide whether you need FFPs, whether you need cryoprecipitates, whether you need this one platelets. Okay. And whether you need tranexamic acid, because this result will tell. Usually the difference between ROTAM and TAG is in one of them, actually the cup is moving. There is a cup in which there is a, like, I don't know too much. I have not seen TAG. I have just used ROTAM. So in the ROTAM, Actually, the cup is static, the blood where the blood is there, and there is a needle which is moving. So that is rotational thromboelastometry. And in the tag, there is a needle above the blood, and the cup is moving. So there are chances that if the place where the technician who is doing the performing the test, if the place is not stable and it moves, the result may vary. So this is one thing which you should be knowing. Of course, the details we can discuss. I have discussed, actually, you can find in my YouTube channel. I have discussed this topic, but I'm just trying to touch. Actually, this topic is an open ended, so I'm just trying to explain to you whatever you may need with reference to, because in the test you will see INR. I am again repeating INR, PTA, PTT, and then you will be very happy. But there are certain things above it. Then, for example, if the patient is on anticoagulant, okay, and this is different from antiplatelets, and unfortunately I'm still unable to. The names of different anticoagulants and antiplatelets is so confusing. We usually just know heparin and claxine, and platelet and clopidogrel, but there are so many other medications. Unfortunately, rivaroxaban and efiximab and like fundoparinox and lapuridine. Unfortunately, it sucks. But generally, you should be knowing about the names, their duration of action. Okay, because duration of action will tell you, and plasma half life. So remember one thing, this is another important thing which you should be knowing when you are evaluating any patient. At least 4 to 5 half lives will be finished before their effects will be clinical effects will go. I repeat that at least 4 to 5 half lives. For example, if a drug has 4 hours half life, so maybe still it will be there, and some medications will have still there will be have some effect. So you should be taking care of this thing. And then there are some oral anticoagulant, which is warfarin. Okay, and so whenever you are evaluating any patient who is on warfarin, then you have to decide whether you can stop it or no. Okay, so there will be always, you have to assess. There will be two things which should be in mind: bleeding versus thrombosis risk. Okay, if there is more risk of thrombosis, then you will go for bridging. Okay, you will go for bridging. And bridging maybe with the you can start with the, like, you will stop warfarin and then you will start this claxane low molecular weight. Okay, and maybe you continue heparin, then accordingly you will stop. Okay, so this is a detailed topic. I'm just giving you an insight. So you should be knowing this. And if the patient is having antiplatelets, so aspirin, according to our guidelines, we can continue even for central neuraxial block. Though, again, I say that sometimes population group is very important. Okay, in our part of world, for example, if I say Indo-Pak and India and Pakistan, we people are taking a lot of food which has antiplatelet activity. Actually, the garlic, we use a lot of garlic in our food. So garlic is actually it is sort of antiplatelet and anticoagulant effect. So, like, maybe the results, the studies are different in different population, but they have made that guidelines. So theoretically you can continue with it, but again, I'm telling you, a practical, if you have any doubt, it is better to just discuss the whole scenario with the patient and the cardiologist, and the reason you should evaluate the whole situation before stopping anything. Okay, but clopidogrel, you need to stop it 4 to 5 days. And even aspirin, if you want to finish its effect, because these medication, they inhibit platelet. So till the time new platelets are formed, their effect will cannot be reversed. Okay, so this is something which you should be just knowing. Otherwise, if the patient is on clopidogrel and you need to do a surgery, then you need to transfuse some platelets. Again, remember one thing, one more point I just want to share, that platelet transfusion or even FFP's transfusion or even cryoprecipitate transfusion, it is not only to correct the numbers. Oh, very good, we correct the numbers. And thank you very much. Patient will be coming with the thrombosis. Okay. Especially in liver transplant, we are following Rotem, but always we are one step behind, and we should be one step behind. We should not. We have Rotem. Oh, thank you very much. We have advanced technology. We will correct the Rotem. Oh, this rotam is showing this thing, tag is showing this thing, INR is showing this thing, we have to correct it. No, you have to see the clinical situation. If the clinically there is no oozing, a patient is doing fine, there is nothing much coming in the drains, you will not try to correct the numbers. So keep this thing in your mind. There are certain indication in which you have to transfuse this 1:1. That is something else. That is in a different scenario in which they have a, like you can say, isovolemic loss, like total blood loss. That is in acute shock in a normal patient. That is something else in which, because whole of the blood is going out without any pathology, things will be different. But in otherwise, remember one thing: whenever you are transfusing platelets or FFPs or cryoprecipitates, or you are giving PGF2 alpha, or doing anything, so any not PGF2 alpha, sorry, factor 7, anything like that, please be very careful. Even tranexamic acid, people are using tranexamic acid like Saudi gawa. It's not that like that, remember, because tranexamic acid is antifibrinolytic. Okay, antifibrinolytic. So antifibrinolytic function, yes, you can use it in any surgery where there is microvascular oozing, but it is not for, my dear, if you injure a main vessel, artery or vein, it will not go there and stop it like askari. Okay, it will not do like that. So don't consider that tranexamic acid is replacement for any surgical bleed. It is for microvascular oozing. Okay, and it has very good effect if you are using it for arthroscopies, for orthopedic tumor surgeries. Okay, and spine surgeries, even ENT surgeries. But remember one thing: surgeons usually they are asking to give 1 gram bolus. It is always give it. It is always recommended to give it slowly rather than a full blown bolus. And it is better to continue it in an infusion around maybe roughly 10 milligram per kg per hour bolus and 10 milligram per kg per hour, like that, roughly like that, 5 to 10 milligram per kg per hour. You will find the doses. I'm just telling you a practical aspect. Maybe in the book you will find something different, but I'm telling you the aspect because it is better, because it can cause thrombosis. Mark my words, tranexamic acid bolus is maybe associated with, especially I give you an example. You are doing a surgery in a prone position. You are doing a supine surgery in a prone position. Now surgeon is asking for hypotensive anesthesia. Okay, now the patient is having hypotension, then there is a pressure on the eye, it's a prone position, the eye is hanging. Number one risk factor, prone position. Number two, hypotensive anesthesia. And now he's asking you to give this tranexamic acid. So all these things can compound. And if, for example, if patient has comorbidities with some retinopathies or some baseline atherosclerosis or like any vascular problem, this patient might end it in having some transient blindness, or it can create some transient vision problem. So be very careful. Okay. So this is just something important, and because everyone is using it without this baseline knowledge. So I just wanted to highlight this thing. So I think this is enough with reference to coagulation, antiplatelets, anticoagulants, INR, platelet function, ROTAM, thromboelastography, and this is with reference to these tests. Okay. So we discuss about renal functions, we discuss about CBC, we discuss about electrolytes, we discuss about renal function tests, we discuss about LFTs, okay, and we discuss about this coagulation profile. These are usually we are doing in commonly. Some other specific tests we are doing, for example, thyroid function. Just few words about it, because I have seen in actually in our setup where I am working right now, hypothyroidism is very common. Every patient, every other day, I'm finding patients who are taking thyroxine. So in that patient, TSH level will be more important. Okay, and remember one thing, that you will thinking that this patient will already be hypothyroid and you are expecting delayed recovery, this and everything. But usually if the patient is getting overdose. So don't forget that this patient can have some hyperthyroid features now because of overdose of thyroxine. This is one important thing you should be considering. Another thing is that you should not skip the dose of thyroxine, because it should only accept oral hypoglycemic agents. Majority medications need to be continued. There is some question mark about ACE inhibitors. Okay, ACE inhibitors, some people will say that if patient is taking multiple antihypertensive agents and especially ACE inhibitors, there is an not clear recommendation, but you can consider to stop it, because, or for example, if patient will continue taking these all antihypertensive, you can expect exaggerated hypotensive response. Okay, so thyroid functions, TSH, T3, T4, you need to do in certain in thyroid condition, you will see it, but you need to know how to interpret it. TSH is usually more important, and free thyroid hormones. Okay. Then specific and for pheochromocytoma, you might need to have this
Sir,
catechol. Yes, yes,
sir, just one question. If a
yes.
question is asked that why is TSH more important than T3 or T4, so what's the answer to that question?
Actually, this will be telling you what is the trend, because it has a feedback mechanism. Okay. So because TSH is controlling it, T3, T4 is a result. So if, for example, TSH is going towards a bad direction, or in a good direction, that is more significant. Okay, because T3, T4 levels may remain on lower side or higher side for some time, but TSH will be responding, or you can tell you in a better way. Free, there are certain other dynamics which can change the free thyroid hormones with reference to albumin, with reference to like plasma protein bindings and everything. Okay, acid base status. There are other factors which can lead to free thyroid hormone. Okay, but TSH is more reliable. Okay, so especially if you are considering for hypothyroidism, TSH is even a better tool. Okay.
Sir, so what about in the case of a pituitary adenoma secreting TSH? In that case, the trend would be opposite to the primary hyper or hypothyroidism.
I apologize, I missed your question. Can you repeat it again?
Sir, like in case of primary hypo or hyperthyroidism, if TSH because of the negative feedback, it gets low in
Okay.
hyperthyroidism and it gets high in hypothyroidism. But in
Yes.
case of a pituitary adenoma, that is not the case. In a pituitary adenoma, the TSH is being secreted that causes the secretion of further secretion of T3 and T4. So
Yes.
that goes against.
No, no, you are absolutely right. But in that case, I am talking purely about thyroid condition. Okay. Because
Okay,
if
sir,
it is,
I
it is,
understand.
if it is other under, because that scenario will be totally different. They not only pituitary, there are certain other condition in which it becomes autonomous. Okay, so that is
Okay, so
different.
like TSH secreting tumors.
Yes. Okay. So there may be especially of course pituitary tumors. Also any other, like there is another big boss, hypothalamus. Okay. So maybe thyroid
Well,
hormone releasing hormone, and then pituitary, and then so it's an axis. But usually I'm just telling you about the normal thyroid dysfunction. If it is through a central mechanism, maybe things will be different. Okay. And again, then
okay,
you have to remember one thing, not make your brain tune in a way that you should be looking at the global perspective rather than only one thing, because one thing will not tell you the complete result. Okay, so in that scenario, of course there will be certain other things. I'm just giving you an of course, if you are looking at thyroid, for example, you will be looking at the pathology, whether it is hyperthyroid or hypothyroid to start with, and then you will go to the cause, and then there will be a lot of factors you will be considering. Then clinical features, if the patient is clinically euthyroid or clinically hyperthyroid or clinically hypothyroid, this is also a consideration. So like you have to see the whole picture, and then you will be able to then again the this you can say the surgical urgency. You will keep on considering all of things. With antihypertension with sip of water on surgery day. Yes, you have to continue. You have to continue all the medications except, as I told you, oral hypoglycemic. Rest of, because you have to, oral hypoglycemics, you cannot have a reliable control, and they are usually long acting. So it is better to stop them. Okay, so few, with reference to few chromocytoma, either the catecholamine levels or urinary catecholamines, you will look at it, and you can go individually a number of investigations which will give you individualized results. Okay, so I will just stop here, because I just, because this is very important thing, and I want you to give an idea of interpretation rather than just rushing up. I will just try to have some words about chest X-ray, ECG, and echo. Okay, so thanks a lot, all of you, for your presence. Feel free to ask any question anytime. All of you are welcome. Okay, so thank you very much. Inshallah, see you again. And remember one thing, I don't have any agenda. I am not doing it for any intention whatsoever, other than I love anesthesia more than I love yesterday. Okay. So I will request you to share this to everyone. And because remember, sometimes we are very miser in sharing different things. Maybe we are thinking, he does not ask me. You did not ask me to take a class, but I'm still taking it. Okay. Out of my family time. So I will suggest you to please do it. Whatever you know, try to share it to others. Because world is now in this situation because of this thing, that we are only thinking about ourselves. We are not thinking about others. And the result is that we are actually declining. Moralities, social values, everything is going down. So try, if you know something, try to tell to others. I just remember the days when I was a resident, or I remember the days when I was stuck in my exam, what sort of condition I had. I was taking beta blockers myself without any reason whatsoever. I was so anxious. Whole of my family was suffering. So that the pain which I suffered that time, I don't want to come out of it. And I am talking to you only because of that reason. I have no impulse to get billionaire with the YouTube channel. You will, if you want to see, you will find a lot of things which I have discussed, of course, in an informal way, because I cannot make presentations and everything. This is beyond my capacity. Number one. And the other thing, I have this Google Drive links which I share with everyone. Anyone wants to ask anything, I am available 24/7. You just drop a message on WhatsApp and I will respond. Okay. uh, Okay, so I take the classes regularly, so you are all are welcome. And just before signing out, I will just again show you. And just a second, please. This is the YouTube channel, okay, and you can find. And if you want to just have a look, you will go to the playlist, okay, and you will find a lot of things. I had some religious teaching all as well in some time, but otherwise you will find, if you are non our not our native speaker, in all the discussions, majority discussions are in English. Before, I had taken some classes in my native language, but after that majority are in English. This is one thing. If you don't understand anything, I humbly request you, no, don't hesitate. You can just drop a message with the link of the discussion we are looking at, that in this discussion, in this minute, what you are saying, we don't understand. Okay. So you will find I have discussed almost all topics, but still, because every time I find new people, so I have again restarted, and I will try to cover as many topics. But my concept, my request or my message is to clear your concept. Don't try to worship books, because no book is perfect, and no book will give you a global vision. Okay, so thank you, all of you. And I actually I share the link for the Google Drive link as well. It has all the articles arranged, because there are two links. One is this Zishan anesthesia data, it was here before. It has a number of books, a number of things which you can help you with questions, FRC, mind maps, hell of books. You will find all sort of books in MCQ's world, this SAQs, short answer question books, this equipment books, some holy textbooks which people worship actually, and I'm totally against, because I will always suggest you to have a look on the articles. Okay, because articles will give you a multi-dimensional view, not a tunnel vision, because the books will give you only a tunnel vision. Okay, so this was unfortunately for last 1 or 2 years I'm not thoroughly putting year wise, because I have taken subscription of a number of articles. So this link is even more important for you. Just give me a second. I share this link a number of time, and anyone if has any query, you can ask. This link actually I share, and actually this is more accurate at the moment with reference to availability of articles, because this is a paid subscription, this is free, this is a paid subscription, and this is also free. This is I'm using someone else, my one of my friend who is in Ireland. I'm using his access, and for this I pay myself. Okay, I'm just sharing it not to impress you, but I'm just telling you the involvement you should also. If for example I am doing so much, I need your response. If you will not attend, or you will not ask question, or you will not share with others, my effort will be futile. It will be useless. So if you open this one, and I have arranged all the articles since their birth. Okay, and even up to May 2023. So I'm just showing it to you. Their mechanism is that this article, this journal is very good academically. Actually, they refresh all their topics in 2 to 3 years always. So maybe if you follow this one, maybe you just need to see maybe 1 or 2 years. I think in last, if you start from 2020, for example, you will find almost all the topics which they have discussed. Same thing. So you can go from the latest and go back, and you will maybe up to here you will find everything. This is one option. This is anesthesia tutorial of the week. I think I forgot to upload few last 1 or 2 articles. Otherwise, you will find all articles arranged year wise. Okay. This is for anesthesia tutorial of the week. Then this is BJ Education. Its name was before CEACCP, Continued Education in Anesthesia, Critical Care and Pain. Again, please, I'm saying to you, my effort will be useless if you don't look at it, and if you don't share it to others, because I'm doing it for all of you. If you will see it, you will use it, you will understand it, I will be very happy. This is my success or failure. That's what I can say. So you will find a number of topics here, and this is another thing which is actually nearer to anesthesia tutorial of the week, but this is in form of summary. Okay, so this is they print every other year, or like the last was in last year in May 2022. They sometimes they print a specific one, like this one. 2019 one was on obstetric anesthesia. Okay, before that, this was in 2015, it was on pediatric anesthesia. I love this edition because a number of things still are valid. Number of things have been changed, but this is excellent for ICU. If someone wants to prepare ICU, if you just delete the latest updates, other things, a number of topics are written very nicely. So you can follow from here. Okay. So that's it. Thank you very much. I share this link a number of times. I think you can, the easiest way you can do is you can just star the message. If you star the message, it will become, you will not miss it. Or you can share this link in your email so that you don't miss it. Okay. So this is one link is most important. And the other link I told you, this one. Okay. And the YouTube channel as I showed you. I'm sorry. So this is the playlist. I have discussed a number of things related to career counseling as well, how to study. I will suggest all of you to listen to these discussions. This is the most important thing for, because you people don't know how to study. I can guarantee that you don't know how to study. You are just wasting your time in the things which are useless, and you are missing the chunk. Them asking you, people are being asked the main point, and you don't know. Okay, anyone wants to have any information, you want to ask about international exams, career counseling, how to appear in Viva, I'm there, always there. I'm just a message away from all of you. Okay. Can you know rather I will ask you to save my number. Okay, and message anyone wants to have a contact with me. This is the message. Please, Abdul Rafi, who is left. Just a second, please. So you can save my number if I think, because you people have joined me from my WhatsApp link. So you can contact anytime to me. I'm there for all of you. Okay. So thank you very much. We will meet inshallah tomorrow, same time. Bye bye.
Sir, can you
Yeah,
share it link, sir, please?
I'm sorry.
Thank
Article. Sir, can you share the link of article, sir? Again.
Just message me on WhatsApp. Okay. You are in my WhatsApp group.
Sir, sir.
You are in my WhatsApp. Sorry.
Yes, sir. Yes, sir. Yes, sir.
So I think you are also like my other sleeping friends. Okay. So I will request you to wake up. I will request you to wake up, have some naloxone, have some doxapram, have some flumazenil, and just stay with me. Okay.
Inshallah, I will try to follow you, sir. From today
Thanks a lot.
onwards, sir. Inshallah.
No problem. I will
कोई
share
special दवाई
the
सर
message,
सर
but
सर
my
निशान
request is
स्पेशल
to
दवाई भी दे दे
my
सर स्पेशल
my suggestion will be to just star the message so that you can use the thing which I have arranged for all of you. Okay. Bye bye. Assalamu alaikum warahmatullahi wabarakatuh.